Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and increasingly the impact of COVID-19 on our pediatric patients, as well as some related potential outbreak-associated viral and other infections. So this is the week of September 19th, 2022. We have heard from the federal government that the pandemic is close to being declared over, and in some parts of the government it is over. I think the news is perhaps a little bit more mottled here in Arizona, where several of our large counties say, hey, we're not done yet, we still have some work to do. And indeed, there are still sporadic cases in the adult world and certainly in the pediatric world, and unfortunately still some deaths in patients with underlying comorbidities. So we continue much as we have in the last several weeks and months with Omicron BA5 and BA4 still making a stamp upon health in the United States. And yes, the cases may have plateaued to actually decreasing by 8 to 9% worldwide every week, but there's still stuff out there. In keeping with an evolution of the messaging of this podcast, first news item, if you will, has to do with outcomes or relatedness to the pandemic and the viral infection itself. And this big one actually comes from a newly released study looking at cardiac involvement in COVID-19 survivors. And as it turns out, this is a relatively focused study, 346 previously healthy COVID-19 survivors, these are all adults, and that study found that 73%, almost 3/4, still had cardiac signs and symptoms more than 3 months after infection, and 57%, so almost 60%, still had them at nearly 1 year. Equal numbers of men and women in the study turned out to have had these persistent symptoms, and a majority of the symptoms were shortness of breath during exertion, almost 2/3, palpitations over a quarter, chest pain over a quarter, and even fainting. So why do I share this? It's an adult study, and it's quite concerning to find persistence of cardiac symptomatology 1 year out. Well, as it turns out, the studies that we have in pediatrics have found that pediatric patients have persistent disease only about 3 months after their onset of COVID-19. However, and here's the point, those studies were done earlier in the beta, alpha, and delta stages in patients who presented with MIS-C, which may be a slightly different immunologic pathophysiology in terms of the impact on the heart. So this is, I think, sort of a mild red flag for those of us practicing pediatrics, in that we don't know what we don't know. And in the adult world, the study has been kind of an earth shaker because it was unclear until now demonstrated that cardiac disease persisted that long in adult survivors, and it was not clear because it had not been studied. So it is very possible that we may find children and adolescents in our practices that have similar persistence of those symptoms. Whether you wish to count that as long COVID or post-acute COVID-19 syndrome PACS doesn't really matter. The point is, there are probably more peds survivors of COVID-19 out there who are going to have at least a year's worth of cardiac symptoms, and it behooves us to screen for those in those kids that we know had disease. So, word to the wise, there you go. Fun and games as always. Now, the next 3 issues to discuss come to us from the chapter based on news and questions raised nationally. And so I think it's actually quite pertinent to share with you all today. First is, now that the bivalent booster shots are available, what do we do if the wrong vaccine is administered? So once again, the bivalent vaccines exist in both Pfizer and Moderna. The Moderna bivalent vaccine, which is still half the dose of the regular strength, is still emergency use authorized only for age 18 and up. However, the Pfizer is approved for age 12 and up. So it is possible that there may be some mix-up in our peds practices because the Pfizer bivalent vaccine may be in your vaccine fridges or wherever you're keeping them, and there's the potential for giving the wrong one. So here's what to do. If one is intending to give a bivalent booster dose to a child 12 and up and instead gives the monovalent, in general, we don't need to repeat the dose. However, what you should do is mark that patient to get the bivalent booster, the proper one, 2 months after that monovalent was given. So basically, there's no harm to any of this. It's just a matter of achieving the intended proper protection. And I think that's sort of the biggest concern here. So at some point, the child 12 and up does need to get the bivalent vaccine. What happens if accidentally the bivalent is administered to a child under age 10 as an appropriate booster dose? And again, kids ages 5 and up can be administered a booster dose based on the original series if they receive their first 2 doses of an mRNA vaccine. Well, as it turns out, again, there's no dangers, there's proven risk. The reason that the bivalent vaccine is not yet approved for under age 12 is simply that the safety studies have not yet been conducted. However, by extension from the other safety studies from Pfizer, there is not even theoretic risk. So if the kid under age 12, older than age 5, accidentally gets a booster with bivalent, no harm, no foul, just consider that their booster dose and keep on going. Here's, I think, the next part, though, is perhaps a little bit more important. So if we're now giving accidentally a bivalent vaccine dose as part of a primary series, so that one of the first 2 doses that we're trying to give to children, if it's the Pfizer bivalent vaccine, you do not need to repeat the dose because the Pfizer bivalent booster is the full strength. If it's the Moderna, that's only half strength, half of the aliquot as the full strength. So if you accidentally give the Moderna bivalent booster as a primary dose, give a second dose immediately, same day, same visit, obviously, if you can. Even if the child was sent home from that shot, that first clinic visit, and you discover the error, bring it back that day and give it to them right away. If not, if you've missed it for 1 or 2 days, then bring them back in 2 weeks and give the second Moderna bivalent vaccine dose then. Okay. Next question then is there any updated guidance for observations following the COVID-19 vaccines, just with the new products out there and additional emerging awareness of safety? And there are no major changes. So obviously, routine vaccine approach, identify the vaccine, identify the child, and depending on your assessment of the child's level of anxiety, whatever, they should certainly be seated or lying down, as syncope may occur, but that's not specific to the COVID-19 vaccines. That would be any vaccine. What the CDC recommends, and picked up by the American Academy of Pediatrics, is to consider observing your vaccine recipients, all of them, especially adolescents, for 15 minutes after vaccine. And that's very typical. We did that in the drive-through shot clinics in the early days. Those patients, both teens and also children with some specific medical histories, for example, prior reaction to a vaccine, prior reaction to a first dose of COVID-19 vaccine, anaphylaxis or allergic reaction after any other vaccine or injectable therapy, those are all children and adolescents that should be observed for 30 minutes. So really there's been no discernible changes, just being cautious, erring on the side of observing longer just in case. But by and large, both anecdotally and per the reports through the AAP, our PEDS patients are tolerating their mRNA vaccines for COVID-19 quite well. Minimal reports of post-vaccine reactions. So the third area of question that is part of today's podcast is actually unrelated to COVID-19, but it's one of those related, potentially emerging infectious diseases, and this is having to do with concerns for emerging acute flaccid myelitis, AFM, which has been and today is linked to infection with enterovirus D68. Now, that entity itself is not new. We've had approximately every 2 years clusters of cases, typically in the mid to later summer, of patients developing a very rapidly progressive flaccid paralysis, keeping with acute flaccid myelitis. They have typical MRI changes, especially involving the gray matter, and will present, much as you may recall from a patient with Guillain-Barré syndrome, although it may not be so clearly ascending as with Guillain-Barré Guillain-Barré, but certainly it can be a fairly rapid global onset of paralysis and loss of reflexes. That entity has been known, and we've been encouraged every several years to be on the lookout for such cases. Well, this is one such year. So there have been cases already reported nationally, several here in Arizona that are under investigation. So that by itself is important to be aware of, that child presenting with decreased tone, easy fatigability, have a low threshold to refer the patient for more advanced neurologic testing and MRI images, especially of the brain, but potentially also brain and spine. But certainly I would consider doing that in consultation with a pediatric neurologist and potentially pediatric infectious diseases. Fine, great, wonderful. What's the big deal specifically? Well, as of now, a little over a week ago, the CDC released a health advisory notice, an HAN, having to do with the rhinovirus enteroviruses that we're all seeing causing significant severe respiratory illness. I'm not sure about your practices, but certainly in my part of the world, in our hospital, we have multiple children hospitalized even right now with severe reactive airway disease, asthma exacerbations, even respiratory failure in a non-known reactive airway disease patient, all with rhino/enterovirus testing positive on their respiratory PCR panels. So a word about that rhino-entro positivity. You're like, why is it like two viruses combined into one? Is it two viruses for sure? No. What actually is happening are the PCR primers on most respiratory panels are unable to distinguish between rhinovirus subtype C and your typical enteroviruses. So they're reported out as sort of a combination virus, both of which have respiratory pathogenesis or tropism, you might say. And whichever virus is triggering the positive is, at least this year, this summer, right now, specifically causing severe respiratory disease. It doesn't stop there. The health advisory also notes that buried within all those patients who are testing positive for rhino/enterovirus are some patients who also happen to have enterovirus D68. Yikes. So that means that virus is clinically circulating. It's active in our communities right now today as I speak, and therefore the risk for those children developing acute flaccid myelitis is real. So we're encouraged to A, have a low threshold for investigating any neurologic progressive disease as a possible acute flaccid myelitis, and B, to be aware that there's going to be a higher volume of such children because the virus is already in the community, and we won't be able to tell just based on the respiratory PCR panel if it's the enterovirus D68 or if it's another enterovirus or rhinovirus C, which is causing our patients severe respiratory illness. So what to do if you have that patient who you think might have acute flaccid myelitis? As noted, have a low threshold to reach out to your neurology and infectious disease consultations, and also on the CDC website, and you can link it through the American Academy of Pediatrics website, are specific case descriptions and reporting structures for what to do in that case. The easiest answer for you is to reach out to your local county health department that already knows those escalation steps, how to reach out to the CDC, and also how to arrange testing of your patient through either your clinic, your emergency department, your hospital to get to the CDC. And in fact, we're doing one such testing right now, shared patient between Phoenix and Tucson. So it's out there, folks. And just when we thought we were through and free and easy of all the COVID-19 hoopla, we're not. Also comes yet another reemergence of entity which has been there and will continue, I think, to circulate every couple years, including this year. Along the similar lines, update on monkeypox. That also, as an outbreak in the United States, has been trending down with a significant intervention in terms of social behavioral practices by the LGBTQ community, which is amazing and fantastic. But also, I think as one is able to start providing more thorough post-exposure and beginning to be pre-exposure prophylaxis with the Jynneos smallpox/monkeypox vaccine, those numbers are decreasing. However, there are still pediatric cases that have been described. To date, the ones that have been released in terms of information, either through publication or through listserv notice through the CDC, through the AAP, all those children had a specific and known contact with an adult provider, care provider, that was either high risk for having monkeypox or had actual confirmed disease or probable disease. So once again, as we see all those kids with rashes for lots of other reasons, whether it's allergies or erythema multiforme or Coxsackie virus, hand, foot, and mouth syndrome, or you name it, herpes, varicella, etc. Buried in there may be a monkeypox patient who is a pediatric patient, but the screening for epidemiologic exposure is going to be your critical component for how to discern that, then how to coordinate additional testing. Once again, if you have a patient in whom you think may have monkeypox, your next step is to reach out to your county health department or county health department officer with that concern, and they will help you coordinate next steps for evaluation, management, etc., and so forth. Boy, that's kind of it. And not that that's it. There's a lot there, unfortunately. And what's coming down the pipeline, of course, is looking at the flu season. Current predictions are that we'll have a nastier than usual influenza season, only because the last several were either absent or somewhat more mild. So as vaccine starts to be released, and certainly as of September 1st they're available, we can now start up a very important annual flu vaccine campaign to try and mitigate not just disease in our kids, of course, but also transmission to their adult care providers, grandparents, etc., and so forth at home. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, hang in there, fight the good fight, and know that you are respected and beloved by all of us. Thanks, everybody.